How does an idea that seems near perfect on paper turn into a lie, and then turn into a policy despite the lie, and then turn back into a lie? Well, let's start with the idea. Turns out that end-of-life care is really expensive. According to one study, a third of all Medicare spending is spent in the last year of life, and of that, 1/3 is spent in the final month. So here's where the near-perfect idea comes in. It also turns out if you have a conversation about end-of-life care with your doctor, you end up getting more effective, less wasteful care without any impact on your life expectancy. So spend less money, get better care, no side effects, negative effects whatsoever. But wait, that's not all. It gets even better. Because in Washington, the icing to any idea cake is a thick layer of bipartisan support, which end-of-life planning had. Here's the Medicare End-of-Life Care Planning Act of 2007, sponsored by a Democrat and co-sponsored by Republican Senator Johnny Isakson. So that's the near-perfect idea. Reimburse doctors for the time they spend talking to patients about what kind of end-of-life care they want. And that idea was part of the Obama administration's health reform plan until this happened.
Be saying, no, you can't give this person a hip replacement. They're too old. This will be done by this federal board, which is really the death panel that Sarah Palin was talking about.
The death panels, yes, back in the news again.
He warned Americans about so-called death panels.
Those death panels, which created a big controversy.
Thus, a near-perfect idea became a lie in what was that, 30 seconds? So the money-saving, eminently humane, formerly bipartisan idea was taken out of the health reform bill signed into law last year. But remember, that's not the end of the story. The near-perfect idea became a lie, but then, amazingly, it turned into a policy. Wait, what? Yes, thanks to a provisional change in Medicare regulation last month, quote, the government will pay doctors who advise patients on options for end-of-life care. A near-perfect idea to a lie to a policy, and then today, apparently haunted by the specter of another round of pulling the plug on grandma, the Obama administration reversed itself. In new Medicare regulations, the explicit inclusion of end-of-life care as part of Medicare reimbursement has been rescinded. And honestly, who can blame the White House for wanting to avoid the whole death panel thing again, when it's busy defending all of health reform from the new Republican Congress that wants to repeal it?
This is symbolic. They understand that this is not going to land on the president's desk. It's not likely to pass the Senate, that this is a bit of huff and puff. What this means is going back to a healthcare system where insurance companies are in charge and call the shots, where a child that is sick with a pre-existing condition doesn't have to get coverage in the greatest, strongest, most powerful country on the planet, where seniors don't get help with their prescription drug costs.
A near-perfect idea to a lie, to a policy, and back to a lie, which was celebrated in an email blast today by the right-wing activist who carted around the health care bill and led the whole death panel canard. When Betsy McCoy is applauding the Obama administration, you know Mercury is in retrograde or something more worldly is amiss. Joining us now is Dr. Atul Gawande, surgeon, staff writer at The New Yorker, and author of many books, including The Checklist Manifesto, How to Get Things Right, which is now out in paperback. Dr. Gawande, thanks so much for being here.
Thanks for having me.
So you've written quite eloquently and extensively on end-of-life care. What do you make of this, the arc of end-of-life care policy that we've just laid out?
It is a travesty. The struggle to me as a doctor is seeing what has become this history, which you neatly outlined, of studies over the last couple of years that show that when patients have more time with their doctors and actually have a discussion, especially a terminally ill patient, about their needs as they near the end of life, they get better care. They arrive at better decisions. They're less likely to die in a hospital or in an ICU. And some striking information, including a study this summer showing that, for example, advanced lung cancer patients who end up having discussions with palliative care physicians end up choosing hospice earlier in their course of care, less likely to choose that fourth round of chemotherapy, less likely to end up in the ICU. And guess what? They actually lived 25% longer by avoiding and coming to good decisions about avoiding aggressive care that was harming them more than helping them. And here we're equating these kinds of discussions and the compensation to allow to make it so that doctors are paid to have longer conversations than we do in our 20-minute typical visits that are the expectations of care. Having that opportunity become a debate over death panels, a way of branding an entire legislative package, is ending up leading to a process that'll hurt patients.
It sounds to me like from what I've gotten from the White House today, as they've kind of been dealing with this Time story, it looks like in terms of what they've done in terms of these regulations, you can still, doctors obviously can still be reimbursed for patient visits in which end-of-life care is discussed. So it's not like this has been prohibited. It's just that they're not sort of explicitly identifying it as something that Medicare is going to reimburse. Is that right about the policy?
Yeah, that's right. I'm a cancer surgeon. I have conversations with my patients about their end of life frequently. But I wrote a story about a 35-year-old patient of mine who had I was one of the doctors on her team. She had a lung cancer that was found to be incurable and diagnosed in the 8th month of her pregnancy with her first child, and it turned out to be her only child. And as you walk through, what are all the barriers that came between us and providing good care at the end of life? There were a variety of barriers. One is that there was no one who, it wasn't just that payments were preventing us from having end-of-life care conversations. It was also the fact that these are conversations that no one wants to quite have in a serious way. These are emotional discussions, they take time, and they're really hard to do. I had avoided it with this patient because I just didn't want to talk about the reality that we all knew that she wouldn't make it through the year. So the result was she died in the place that she didn't want to, going back and forth from the hospital and ultimately spending her last days in the hospital rather than with her still not quite 1-year-old child. The truth here is we are in a system of care that does not provide great care for patients with terminal illness. When you have terminal illness, few of the patients are guided to understand the clear options there are early enough to recognize what's the best time to choose, say, hospice care, when's the best time to avoid aggressive treatment. And we need policies as well as teaching that start shifting that norm. And the death panels conversations has chilled that entire conversation.
Dr. Atul Gawande, surgeon, staff writer at The New Yorker, author of the Checklist Manifesto. Thanks so much for joining us tonight. It was really great to talk to you.
It's great to be on.